Welcome back to the deep dive. Today we're tackling what might be our highest stakes mission yet. We're going to synthesize the absolute core non-clinical knowledge you need. Behavioral science, biostatistics, and epidemiology. We're taking this huge pile of source material and, well, boiling it down into wisdom you can actually use.
It's a huge task,
Yeah.
but it's so necessary. You can think of this as the ultimate shortcut to becoming a clinician who is truly well-informed,
Right.
someone who speaks the language of molecular biology, but also public health and the language of humanity. We're going to move fast, but deep.
Okay, so let's unpack this and jump right into Unit 1, epidemiology. At its core, this is really the language of groups. We're stepping away from the individual patient.
Completely.
And we're focusing on the distribution of disease in a population, and that's always expressed, numerically, in ratios. The key thing you have to get is the denominator.
Precisely. If you mess up the denominator, your entire public health calculation is just skewed. And within epi, the first most critical distinction is between incidence and prevalence.
Okay.
Incidence is it's the measure of disease onset. So the number of new cases over a specific time period divided by the number of people who are actually at risk.
So incidence is what you look at for, say, an acute outbreak or to see if a prevention program is working. It's asking, how fast is this happening?
That's it, exactly. And prevalence, on the other hand, is more of a snapshot.
Yeah.
It's the total number of cases old and new divided by the total population at risk.
Which is why we track prevalence for chronic conditions like diabetes. It asks, how many people are dealing with this right now?
Perfect.
And this is where it gets really fascinating. The core mathematical relationship is prevalence equals incidence multiplied by duration. P equals I times D.
Right.
So let's run a scenario. A revolutionary new cure for a chronic disease is found. What happens to those rates?
Okay, so if there's a cure, people stop having the condition. Duration, it shortens dramatically, so prevalence will just drop.
But the incidence might not change at all.
Exactly. The rate of people catching it could be exactly the same. Now let's flip it. What if we get a therapy that prolongs life by 5 years but doesn't actually cure the disease?
Then the duration, D, goes way up. So even if incidence stays the same, the total number of people living with the disease, the prevalence, is going to increase. That's a huge strain on resources.
Understanding the P-IXD relationship is just vital for any kind of public health planning.
Okay, and when we're comparing rates, say, between two cities.
You need standardized or adjusted rates. Crude rates can be so misleading. City A might look sicker than City B, but maybe it just has a much older population.
So you adjust for that.
You adjust for it. You remove those demographic effects to compare apples to apples. If City B still looks sicker after you adjust, then you know there's a real difference in risk.
So to get these rates, we need research. But before that, let's talk about interpreting data from screening tests. The famous 2x2 table.
Ah, yes, the 2x2. True positives, false positives, all that. There are two sets of measures you pull from this table.
Okay.
The first set is sensitivity and specificity, SEN and SPEC. You use these to select a test. They're, baked-in properties of the test itself.
They don't change with the population.
They don't. Sensitivity is the test's ability to find the diseased people. Specificity is its ability to find the healthy people. Simple as that.
But the second set is what you actually use when you're with a patient. The positive and negative predictive values, PPV and NPV.
Exactly. These are for interpreting a result. PPV asks, okay, the test is positive. What's the chance they actually have the disease?
And NPV is the reverse for a negative test.
Right. And unlike sensitivity and specificity, these are massively affected by the prevalence of the disease in the population you're testing.
Let's use an analogy for that. Say you're screening everyone in, Minnesota for a rare tropical parasite with a really good test, 95% sensitive and specific.
It's a great test, but the prevalence is basically zero. So almost every single positive result you get is going to be a false positive.
Your PPV will be terrible.
Awful. You might tell 10 people they have it, and maybe only one actually does. That's why we don't just screen for rare things in low-risk groups. The context is everything.
That makes sense. Okay, so moving from interpretation to where the data comes from, research design. It's either observational or experimental.
Right. Observational is where we just watch. Experimental, like a clinical trial, is where we do something, we intervene.
And the two big observational types we need to know are case control and cohort.
The case control study starts with the outcome. It compares a diseased group to a non-diseased group. Then it looks backward in time. It's retrospective, to find risk factors.
Right.
Great for rare diseases.
And it gives you an odds ratio.
Correct. A cohort study is the other way around. It compares a group with a risk factor to a group without it, and it usually follows them forward in time perspective.
And because you're following them, you can calculate the incidence rate.
And you get a relative risk, or RR, which tells you how much more likely the exposed group is to get the disease.
Perfect. And that relative risk brings us right into biostatistics and the rule about the confidence interval, the CI.
The CI is your margin of error. And the rule is simple. If the 95% confidence interval for an RR includes the number 1.0, the risk is not statistically significant.
Because an RR of 1.0 means no difference in risk.
No difference at all. So if your margin of error includes that point of no effect, you can't be confident your risk factor actually did anything.
Before we dive deeper into the stats, a quick word on a couple of biases that can just wreck a study, like lead time bias.
Ugh, yes. This is a huge trap in screening programs. It's when you mistake early detection for longer survival.
How so?
You find the cancer earlier, so it looks like they live longer since diagnosis, but they might die at the exact same age they would have otherwise. The solution is to measure actual life expectancy, not just time from diagnosis.
And the other big one, maybe the most basic one, is selection bias.
Just comparing apples and oranges. The groups were different from the start.
And the number one solution for that?
Random assignment. If you randomize, the differences between individuals should, even out across the groups, making them comparable.
Which brings us smoothly to Unit 2, biostatistics, making sense of all this data.
So once you have the numbers, you need tools to describe them and then generalize them.
We start with descriptive stats: mean, median, mode, the central tendency.
Right, but the key insight is knowing how the shape of the data's distribution affects those averages.
So in a skewed distribution, they pull apart.
You pull apart. In a negatively skewed distribution, for instance, the tail points left, those low outliers pull the mean down the most. So the order is always mean, median, mode.
And then from describing, we move to inferring.
Inferential statistics. Taking your sample and making an educated guess about the whole population. This is where confidence intervals and p-values are everything.
Let's stick with the CI for a second. Conceptually, it's just our margin of error, right? The true value is probably somewhere around our measurement.
That's the idea. And that rule we mentioned for relative risk, if 1.0 is inside the CI, it's not significant, that holds for odds ratios too. It's a quick way to check the validity of a study's conclusion.
Okay, next up, hypothesis testing. You always start with the null hypothesis,
Which always says there is no difference or the drug doesn't work. And our goal as researchers is to gather enough evidence to be able to reject that null hypothesis.
And in trying to do that, you can make two big mistakes.
Two big errors. The type I error, or alpha, is when you reject the null when it's actually true. You say the drug works when it really doesn't.
That's the sin of commission.
It is. A type 2 error, or beta, is the opposite. You fail to reject the null when it's false. You decide the drug doesn't work when it actually does. That's the sin of omission.
Now wait, a type 2 error, missing out on a good drug, sounds really bad for public health. Why is the type I error usually seen as worse in medicine?
It goes back to that core principle, primum non nocere. First, do no harm. If you make a type I error, you are actively giving people an ineffective treatment that could have side effects, that cost money. You're causing harm based on a faulty conclusion.
That makes sense. And this all leads to the difference between statistical significance and clinical significance.
Yes, a p-value tells you about statistical significance. It just answers, is there a difference?
Yeah.
Clinical significance asks, so what? Does this difference actually matter to a patient?
And a huge sample size can give you a tiny p-value for a totally meaningless effect.
Absolutely. A study with 1 million people could find a statistically significant result for a drug that lowers blood pressure by, 0.5 millimeter of mercury. Statistically real, but clinically, who cares?
Okay, that brings us to our final unit. Unit 3, behavioral science, the human element. Because all these numbers mean nothing if you can't apply them to a real person.
And we start with the absolute core ethical rule. The patient is the decision maker, period. The principle of choice. A competent patient can refuse any treatment, even if it will kill them. We have to respect their autonomy.
And that choice has to be based on informed consent, which is a process, not just a signature.
Right. For it to be valid, the patient has to get and understand 5 things. The nature of what you're proposing, the goal, the benefits, the risks, and the alternatives, all 5.
And the foundation for all of this is competence.
Which is a legal term. Doctors assess capacity, but courts decide competence. And the rule of thumb in the clinic is, if you are not sure, you assume competence until proven otherwise.
What about kids?
Generally, minors are incompetent. But you have this idea of partial emancipation. It usually applies to teens, maybe 14 and up, and lets them get treatment on their own for 4 specific things.
What are they?
Contraceptives, STDs, substance use, and pregnancy care.
Got it. Now, privacy, confidentiality. The rule is simple, right? Don't tell anyone anything.
It's incredibly strict, with one huge dramatic exception: the threat of harm to self or others. This is the duty to warn or protect that came out of the Tarasov case.
It's that moment where your duty shifts from your patient to the public.
An incredible ethical tightrope. And of course, you have mandatory reporting for things like child abuse and elder abuse. That bypasses confidentiality completely.
Okay, let's shift to helping people change, the stages of behavioral change.
Right. Pre-contemplation, contemplation, preparation, action, and maintenance. And your job is to figure out what stage the patient is in.
Because your response has to match their stage. Lecturing someone in pre-contemplation who doesn't even see a problem is just a waste of time.
A total waste. You need to raise awareness. But if someone is in preparation, ready to go in the next 30 days, you suggest a simple small step they can take right now. Make it easy to start.
What about what actually motivates people?
The health belief model is a good guide. It says motivation is about perceived threat, how serious they think the problem is, and how susceptible they feel. And interestingly, it's moderate anxiety about their health that leads to the best results.
Not too little, not too much.
Exactly.
And quickly, some psychological foundations. Piaget's stages.
Yes, in the preoperational stage, so ages 2 to 6, kids are egocentric and they fail the law of conservation. They think the amount of water changes if you pour it into a taller, thinner glass.
Classic. And then defense mechanisms.
How the mind copes. The primitive ones distort reality. Think of denial. That's the first thing you expect when you give someone bad news. Or splitting.
All good or all bad?
All good or all bad. They might see you as the perfect, amazing doctor, and the nurses as completely incompetent. It's a key feature you see in borderline personality disorder.
And the mature defenses are more adaptive.
Like suppression, which is a conscious choice to put a worry aside for later. Or the most mature one, sublimation, where you channel an unacceptable impulse into something productive. The classic example is the bully who becomes a football coach.
Okay, let's wrap up with addiction. What's the core mechanism?
It all comes down to the NAC pathway, the nucleus accumbens. It's a huge dopamine reward center.
And substances hijack it?
They completely hijack it. Natural things like eating a good meal give you a little dopamine squirt. An addictive drug can give you 30 times that amount. It breaks the link between your behavior and normal, healthy feedback.
And the most common drug we deal with is alcohol. Screen with the cage questions. But the withdrawal, that can be deadly.
It can. It progresses from tremors to, in the worst cases, delirium tremens or DTs. That's confusion, agitation, cardiovascular instability. It has a high mortality rate. Recognizing that progression saves lives.
Wow. Okay, that was an incredible tour through really the foundations of modern medicine, how we measure risk, how we interpret data, and how we interact with patients.
It's a ton of critical info. So before we sign off, let's do a quick exercise to lock in one of those core statistical ideas. This is something you, the listener, should be able to do instantly.
Give us the scenario.
A new cohort study says a high-fat diet has a relative risk of 1.5 for heart attacks, a 50% increase. The 95% confidence interval is 0.95 to 0.05. What's the conclusion? And how is that different from an RR of 1.5 with a CI of 1.05, 1.95?
Okay, in both scenarios, the RR is 1.5.
Yeah.
But in that first one, the CI, 0.95, 2.05, it crosses the number 1.0.
Yeah.
And 1.0 is the point of no effect. So even though they found a 50% increase because the margin of error includes 1.0, the result is not statistically significant.
Correct.
In the second example, the CI of 1.95 does not include 1.0. So that 50% increased risk is statistically significant. The key is always whether that interval crosses 1. So the final thought for you to take away is this. Your greatest clinical advantage isn't just knowing the latest drug. It's being able to integrate that kind of statistical objectivity, knowing what that CI means with human complexity, knowing if your patient is in denial or which stage of change they're in. That's what comprehensive care is.
Keep looking for those knowledge nuggets. We'll see you on the next deep dive.